Hi, good morning. We're going to get started with the hematology session. Make sure you're in the right spot. Hematology, we're going to be talking about myeloma, AML, and CAR T therapy. And I'm Dr. Laura Finn. I'm one of the CAGLA board members, I think one of the few hematologists on the board. So the chair of this session was organized with the CAGLA conference in mind for Advocacy. So that's going to be, in addition to science, the focus of our presentations this morning. Our first speaker is Dr. Craig Cole, a professor from Michigan State University in the Division of Hematology and Oncology, and also a clinician at the Carmenes Cancer Institute. He has primary clinical and research interest in multiple myeloma and has presented at national meetings, including the American Society of Hematology. So we're actually thrilled to have him here as a guest speaker in the hematology session of our conference, CAGLA's No Cancer Conference 2024. And his topic today is health disparity in multiple myeloma. Thank you.
Thanks, Laura. And you can tell I made these slides in January because it still has 2023 up there. And I came down from Michigan, and thanks for inviting me. I think this is one of the most important conferences I actually have attended because it has, some marriage of hem-onc people, industry, advocacy groups, patients. And there's nothing really more powerful than those groups coming together. Everyone was like, it was so cold yesterday. And I'm like, it was 27 when I left Michigan. I'm like, it's hot down here. I would have worn shorts if I could have yesterday. So kind of the outline of what we're going to talk about is race, incidence, and myeloma. Talk about some of the differences in risk biology and presentation of myeloma between races and ethnicities. Then some of the disparities in care, some disparities in clinical trials, which a lot of us in both industry, academia, private practice, and in patients are all very invested into. And then some solutions. So first, so this is some new data that I just got from the SEER database, and you can see for all races the incidence of myeloma is 8.2 for men and 5.8 for women for multiple myeloma per 100,000. But you can see for African Americans it's almost double that compared to whites. Double that for African American men and for African American women as compared to white women in all races. And I would definitely, lead your eye to where Native Americans are about how low the incidence is. So yes, you can see that the incidence for men and women is more common in men than in women. And in the U.S. population, the number of blacks with multiple myeloma is about 19 to 20. Really now these days about 21% of the population of myeloma patients. Blacks have twice the incidence of whites. And that's just not blacks in the United States, but that's around the world. There have been publications done in Africa and Jamaica showing that the incidence of this disease is more people of African descent than specifically African Americans. And again, the highest risk group in the world. When you look at, again, incidence, the incidence of myeloma has been rising quickly per 100,000 for blacks that are the top line compared to all other races in the bottom lines. And when you look at mortality, that higher incidence, of course, relates into a higher mortality. And thank goodness, I think you can see that over the past 20 years with multiple myeloma, the mortality has been significantly decreasing for all racial groups. However, we'll talk about this at the end, that has been falling, the mortality has been falling faster for whites than for blacks and other races. When you look at both incidence and mortality overall in the United States, you can see that the Southeast has a higher incidence of myeloma, especially here in Louisiana and in Mississippi. But when you look at their mortality, again, it does reflect the higher incidence. But you can see that there's subtle shades that are different between incidence and mortality with this disease that really highlights some of the inequities of care and inequities at access in particular states that I'll show you, I think, a very striking slide that shows how you can explain some of those disparities that are geographic. So let's talk about some of the differences. So the biggest question I get from African American patients with myeloma is, well, why do black people have such a high incidence of this disease compared to whites? And it's because all myeloma comes from the monoclonal gammopathy of uncertain significance, or the precursor disease to myeloma. Not all MGUS turns into myeloma, but all myeloma stems from MGUS. And the incidence of MGUS is higher in blacks than in whites. And in the U.S. National Health and Nutrition Examine Survey found that MGUS was significantly higher in blacks at 3.7% as compared to other ethnic groups. And I think you can see in the line where the top line is blacks and the other lines are whites, that line of prevalence actually increases earlier than it does for whites, suggesting that the prevalence of blacks this disease occurs earlier. Well, can you explain this higher incidence of MGUS by any of the traditional methods that we look for disparities and disparities in care? Well, we can find that the higher incidence is due to tobacco, education, socioeconomic status, autoimmune disease, chemical exposure. There is a tendency for higher MGUS in people that have a higher BMI. One thing that has been recently published is that the hereditary nature of myeloma. MGUS is more hereditary in blacks than in whites, which may explain the higher incidence, the higher prevalence of MGUS than in blacks than in other ethnic groups. There was a very interesting abstract that was at ASH this year where they went to a small country in South Africa, Eswatini, to look at the incidence of MGUS and found the incidence was markedly high at 13.2%, a lot of those being light chain MGUS. And so I think that gives us an insight into the higher incidence in people of African descent with MGUS and therefore multiple myeloma. Blacks tend to, again, have, in the same way that MGUS occurs earlier in blacks than in other ethnicities, myeloma occurs earlier in blacks than in other ethnicities. They're more likely to present with the myeloma-defining events of anemia, hypercalcemia, and kidney failure. Less likely to have bone fractures because people of African descent have a higher bone density. They have the same number of bone lesions, but less bone fractures as their myeloma-defining event. Blacks are more likely to have translocations of chromosome 14, such as the 11-14 translocation, for which one of our most potent drugs for myeloma, specifically for 11-14, is very active. There was another abstract at ASH that was, I think, very interesting that showed that the mutational burden in whites for multiple myeloma is higher than in blacks. And some of the clock-like mutations that are found in myeloma were much more common in whites than in blacks, which may lead to some of the differences in outcomes if all things being equal, and I'll talk about that in a couple seconds. Blacks are less likely to have the high-risk cytogenetic lesions by FISH and multiple myeloma, and specifically the additions and amplifications of chromosome 1, 414, 1417, and, of course, the deletion of 17p, which is some of the high-risk lesions that we see in myeloma, which, of course, are more difficult to treat. So there are biologic differences between the races with multiple myeloma, just not in incidence, but also in mutational burden, cytogenetics, and risk. So now about the disparities in care, things that we can't control our genes. But we can try to work to annihilate some of these disparities that we see in care. The SEER database looked at about 5,000 patients and found that there was lenalidomide, one of our main backbone drug to treat newly diagnosed myeloma, that it's a lower utilization in the United States for African Americans and lower use of bertuzumab, our other main backbone drug for induction therapy for myeloma, were lower in Asians. Hispanics had a longer time to receive bertuzumab. And you can see that from the study from 2017, the use of triplet therapy are, again, the main backbone, the main way we treat myeloma in the United States was lower in blacks than in whites. And stem cell transplant, again, one of our main ways to treat myeloma and keep it into a response is lower utilization. I'll talk about that in a bit. There was an abstract, again, at ASH this year that showed that not only in recent time, this was a Flatiron study, again, that was an abstract in 2023, showing, again, even to this day, lower triplet utilization for black patients than whites, and looking at fish cytogenetics, which is really the standard of care, our genomic assessment for myeloma, lower utilization for blacks than for whites. It takes longer to diagnose blacks and women with myeloma, and a longer time that it takes to initiate therapy, even though we've gotten better at initiating therapy within the first 6 months. We still, again, continue, blacks and Hispanics continue to lag behind whites in initiation of therapy and in time of diagnosis. That initiation of therapy in a more recent study was longer for women and in blacks than for whites. Again, stem cell transplantation has been shown to have a progression-free survival advantage for myeloma patients that are transplant eligible. And in a CIMBTR study from 2005 to 2019, again, lower utilization rates for blacks, Hispanics, and Asians compared to whites. And that disparity, racial disparity itself, prevented 1 in 7 stem cell transplants, and almost half of those transplants occurred because of disparity to access. You can see that the utilization ratios significantly different for people of ethnicity than compared to whites. When looking at factors which resulted in lower use of stem cell transplant, again, blacks, Asian race, Hispanic ethnicity, older age, lower socioeconomic outcome, or socioeconomic status, residents in metro areas, although a lot of our academic centers are located in metro areas, the people immediately around those academic centers don't get transplanted. And of course, low insurance. The racial disparity in access to stem cell transplant persists even when adjusted for income. And there's a lot of physician bias. I actually caught one of our fellows who had a black patient who was obese, who was, I think, like 60-something. And she said, well, this patient isn't a transplant. I mean, I was just getting my mail. It wasn't my patient. I was just getting my mail. And I overheard her say, well, that patient's not a stem cell transplant candidate. And I turned around, I was like, why? Well, she has too many comorbidities. And I said, you're a fellow, very smart. She's a super good fellow. But that's not your decision to make if this patient is a stem cell transplant candidate or not, because her BMI is high and because of her ethnicity and comorbidities. And so that was part of her bias that made that decision, because studies have shown that when you put black patients and Hispanic and Asian patients in front of the transplanter, they are just as likely to want the transplant as other ethnic and racial groups. There's lower utilization for maintenance therapy for blacks and, of course, people that are underinsured. Our main maintenance therapy is lenalidomide, and I think, you may or may not know that lenalidomide is about $17,000 a month for maintenance therapy. The therapy that has been shown to increase progression-free survival, and in some studies, overall survival with myeloma. So being poor with this disease will kill you. I have said that over and over again. When we do our staging for myeloma, we should have as part of it the cost and the insurance, because that will kill you more than 17P and other high-risk lesions, unfortunately, in this country and around the world. Also, using bone strengthening therapy, again, lower utilization in blacks and in people who are underinsured, based on 2 different studies, which is, of course, terribly unfortunate. So this, I think, is one of a slide that I've had in my slide deck for a long time, and every time I look at it, it always disturbs me that when looking at socioeconomic factors and survival from myeloma, patients aged 65 who are privately insured lived longer with this disease than those who were that had less insurance, specifically Medicaid and Medicare. Treatment at academic centers, patients had a better survival, longer survival. I always look at that as really and I have some of my colleagues who say, gosh, that just means that myeloma doctors are great. And I said, no, that means myeloma doctors are terrible, because we have not been able to get across and not have been able to educate our colleagues in the community so that everyone treats myeloma patients the same way that I treat them. That is the ownership that is on us to have ways to treat myeloma that are clear, that are logical, and that are inexpensive yet effective, so that we can move that line away from academics and have survival equal across the country. Younger age, fewer comorbidities, treatment in academic centers had high, that stage and risk isn't in there. It is all things that are changeable. That result in differences in survival and outcome in patients with myeloma. Well, what if, all things being equal, the famous VA study where, everyone at the VA gets the exact, I worked at the VA for 7 years, and when I was at University of Michigan, everyone gets the same therapy at the VA. When they looked at VA survival, black patients had superior overall survival in younger myeloma patients than in whites. For older myeloma patients, it was about equal. And again, there's no racial disparity or insurance problems within the VA system. Everyone gets treated the same. This same outcome has been seen in multiple studies that have looked at, including the COMPASS study and a couple other studies where the delivery of care has been equal across the board. But there are differences, and one of the more disturbing things I think that we'll talk about a bit in the clinical trials is some of the side effects that we see with long-term Revlimid use. That in 2021, a study looked at toxicities among blacks and people who are darker skinned with lenalidomide, and find that hyperpigmentation was reported in 41% of patients. Revlimid came out in 2021. And it took 20 years for a paper to be published showing this toxicity. I've had patients who have stopped lenalidomide because of changes that happened to their skin. I have had lots of patients that have been disturbed saying, what is this change happening? There was no data written on this until 2021, which is really disturbing that this side effect has existed that long and it hasn't been reported because of low enrollment of blacks on the initial lenalidomide trials, and I'll show you that in a second. A more recent paper that was written about CAR-T and ethnicity outcomes, again, that there are some differences. The black patients were more likely than white Hispanic patients to have any grade CRS, longer hospital stays, but not severe CRS. The overall survival, and I think you can see in the graphs that the one group that has the lower bar are Hispanics with overall survival at all time points, that the overall survival was lower among Hispanic patients compared to blacks. However, there was no racial ethnic differences in progression for your overall survival. So again, there are differences that we need to ferret out more in regards to CAR-T and of course with myeloma in general. And then there's the famous determination study, the RVD plus transplant versus RVD and no transplant study that has a New England Journal of Medicine paper, has had a couple abstracts at ASH in 2022 and 2023. And in 2022, the headline of the transplant versus no transplant study showed that PFS was longer with transplant compared to no transplant, but overall survival was the same. Looking at Black patients, the PFS for RVD alone was not reached compared to those that got transplanted, where it was 61 months. And then more recently, the determination study, Paul Richardson and Jeff Sonder showed the PFS is longer for Black patients with higher BMI than without transplant than with transplant. You can see that the blue dots are white patients getting a transplant versus no transplant. Again, for whites, transplant shows benefit with progression-free survival. But for Blacks, it's kind of a mixed crowd, with women having having a PFS that's better without transplant, high BMI without transplant. Does that mean that we shouldn't transplant Black patients? Absolutely not. What that means is that we need to investigate why this phenomenon was seen with this trial, and to see why are these differences. Because again, I've mentioned there's some biologic differences in myeloma between Blacks, Hispanics, and whites. We need to ferret this out more, but you should definitely recommend transplant to your Black myeloma patients until we can ferret this out a bit further. So again, disparities in clinical trial. And I thought, I was at a meeting with the FDA, and I thought that this is one of the most important lessons that I think I have learned, that if trials don't include minority groups, it is always a question if the results of these studies are relevant to everyone. There's no way that you can cure multiple myeloma without curing it for everyone. In order to cure for everyone, you need to have an appropriate representation of ethnic groups on these trials. Again, the number of Blacks in the United States living with myeloma or with myeloma is about 20%, but those involved in clinical trials is less than 5%. And this was kind of the map that I wanted to kind of bring up again, is that death rates for myeloma for Blacks are in red. For other races is in gray, and green is our Hispanic patients. The blue dots are where the clinical trials are taking place. And you can see that there are huge areas in this country, especially in the southeast, where there are increased death of myeloma, but no clinical trial access. And the catchment area for those areas are how big the circle is. And you can see that even where I am in Michigan, there are areas that are clinical trial and therapeutic deserts where patients are neither getting diagnosed nor have access to clinical trials in this country. And that results in excess, and I would say unneeded mortality with this disease. The FDA looked at clinical trials that were brought for registration trials brought for approval to the FDA with multiple myeloma, and found that the median percentage of Black patients is 4.5%. Remember I talked about the darkening of the skin in patients with lenalidomide? It can't be a surprise that those lenalidomide trials had between 1% to 2% enrollment of Black patients. So how is that clinical trial, when they went to approval to the FDA, how is it not a surprise that some of the toxicities like that, changes in skin color, were not seen because Black patients weren't enrolled in the trial in sufficient numbers? A more recent analysis of FDA registration trials for multiple myeloma, again, we do very poorly at enrolling older patients with myeloma. I showed you that the incidence for Black men with myeloma is about 16.8 per 100,000. For patients 85 and above, it's like 70 per 100,000. The incidence of this disease is super high with the elderly patients, yet we don't enroll them in our clinical trials. Again, outside the United States, we enrolled very poorly with different ethnic groups on clinical trials. In the United States, we're getting better. In Hispanic patients, still, and I just showed you how with CAR T, we're seeing differences in some of the overall response rates, yet we're enrolling low numbers of Hispanics in our clinical trials. And again, in an abstract that was at ASH this year looking at CAR T therapies, again, 81% of those CAR T registration trials had whites, very small number of blacks and Hispanics. We need, because of these biologic differences, we need to enroll more diverse groups on the clinical trials. And some people would say, well, what harm is there in enrolling low numbers of different ethnicities in clinical trials? Well, all of our guidelines are based on clinical trials. Therefore, if we don't enroll numbers of ethnic groups on clinical trials, the guidelines will be skewed. In the IMW International Myeloma Group guidelines, of which I'm part of the IMWG, that only 2.6 of those 5 million patients that are the studies that are used to base those guidelines on were black patients. And so how can you, and the authors of the paper said that if guidelines are developed on clinical studies that don't reflect the racial composition of the population, you're going to get inaccurate recommendations. That is what happens when you don't enroll diverse groups on clinical trials. So are there solutions? Yes, there are solutions. And thank goodness that a couple years ago, the FDA, after several meetings, I'm sure in the myeloma community, but also outside of it, brought up their initiative to increase racial diversity in clinical trials, including their guideline. And I think this is a fantastic document. I don't like reading government documents because it always scares me, but this is a super good document to look at. It's actually very, very intuitive, very easy to read, but gives a phenomenal number of suggestions in how to write clinical trials that are more inclusive. The FDA also looked at screen failures, so patients that screen failed for clinical trials, and found that black patients had higher ineligibility rates than in white patients, with failure to meet lab criteria being the number one reason. What was that failure of lab criteria? Neutropenia. That there is the Duffy-Null phenotype, which causes people of African descent have lower baseline neutrophil counts than whites. Whites are the majority in the country, therefore the normal neutrophil counts place at the white level as opposed to the black level, which is lower. And I have written clinical trials where I've cut and pasted from old clinical trials. I use the exact same parameters that those old trials did. I had to catch myself. I said, Craig, you can't do that, because that will exclude, by just simple cut and pasting, I excluded a bunch of black patients from a clinical trial that I was writing. And so, and looking at, we still need to understand what the Dull-Null phenotype has to do with myeloma. And the determination trial actually found I think, a significant number of Duffy-Null patients in their study. One thing that I hear is that, well, blacks and Hispanics and Asians don't want to go on clinical trials. That is not true. That is that is absolutely not true. Actually, blacks, Hispanics, and Asians are more likely to want to go on cancer clinical trials than their other cohorts. And again, at ASH, there was an abstract where they had a focus group with myeloma patients. And again, they were very enthusiastic about enrolling on clinical trials. And so we wrote a paper a couple months ago that gave, I thought, some very thoughtful recommendations. And actually, this paper was from the Multiple Myeloma Research Foundation, 2 different focus groups that we had with industry patients and researchers and the FDA present. And one thing we need to do is we need to change clinical trial design. To develop diversity plans at the beginning of writing clinical trials, to broaden our eligibility criteria, not only for anemia, but also for comorbidities, have a standard capture for race and ethnicity data, to be ready to look and sub-analyze these groups to look for differences in pharmacokinetics and toxicities, and utilize public available guidance documents like the FDA. Clinical trial operations reduce the burden for patients. And I would say one of the more important ones is select places for clinical trials that we haven't looked at yet. Decentralizing clinical trials. I showed you those clinical trial deserts through the Southwest and really throughout the country, especially in the West. We need to have clinical trials available for everyone, decentralizing clinical trials away from the big centers to the people, and then making patient education engagement more, especially by getting patients involved in the clinical trials while they're written. Sickle cell anemia had a ton of drug approvals in very quick order, very successful engagement of patients on clinical trials. Part of the reason they did that is they had patients involved in the design of those clinical trials to set the endpoints and the primary endpoints for these trials, and therefore patients being involved have better recruitment of patients on those trials. So patients with African descent have twice the incidence of myeloma, MGUS and myeloma compared to other ethnic and racial groups. The biology presentation are different between those of African descent and European descent. And those disparities, and there are significant disparities in care. A lot of those are social economic. Some of those are biasness that we need to overcome. And there are a social economic status, again, being poor will kill you with this disease. With equal delivery of care, the good news is that the outcomes are equal and maybe superior for people of African descent. And again, as I mentioned at the beginning, that there's been that patients with minority race had a less increase in population level survival in the 21st century than white patients. We need appropriate representation on clinical trials, and there are ongoing things to try to mitigate that. So this is one of my favorite sayings. I actually bolded it and made it bigger than my original slide. That now that you are aware of the problem, now that you're aware, I'll be honest that when 10 years ago, when I was enrolling in clinical trials, I did not think of putting diverse populations in clinical trials. I was interested in getting enrollments done. Now that I have been aware, I have made a change, and I hope that you will too. And that's Disparity. And thank you for your time and attention.